Good evening, everyone. Thank
Evening.
you, Abhi and Jody, for coordinating. So, as a surgeon, I'm going to talk about obesity and metabolic surgery. So, as you know, obesity is a chronic disease of excess fat storage sufficient to harm your health. The cause of obesity is multifactorial, and obesity leads to multiple other diseases associated with that's what we call comorbidities. It is significant impact on the quality of life. It is costly to treat and manage, and it could be potentially fatal. So we know that obesity is now a global epidemic. And if you look into this graph, currently there are 2 billion people across the globe are obese or overweight. Out of them, 600 million or more than 35 BMI and 100 million or more than 35 BMI. And unless the whole world works together to change the changes which are necessary to change this obesogenic environment is going to rise maybe up to 2.7 billion in 2025. So two things we need to know. One is the weight and the other one, the waist circumference, because the waist circumference indicates the central obesity, which is harmful. So we sometimes measure. So the normal healthy weight is between 20-25 or you can 18.5 to 25. You're overweight when your BMI is 25 to below 30. Then anything more than 30 is obesity. Then you can say class 1, 2, 3. 3 means more than 40 BMI. So along with the weight, if the waist circumference is high or very high, then that can lead to diabetes, blood pressure, and sleep apnea, all the potential risks with obesity. We know we are surrounded with obesogenic food with high density in calories. In the past, we were slim and our TVs were bulkier. Now the other way around. And one of the worrying facts in UK, at least nearly sort of 60% of adults are obese or overweight, whereas a quarter of them in children are also obese. So it we have to look closer how we can tackle this obesity epidemic. So what is the cause of obesity? It is not just simply a result of overeating. It is a complex disorder involving appetite regulation and energy metabolism. And the causes of it could be genetic, environmental, psychological, and physical. So this graph gives there is not a single organ of the body which is not affected by obesity. If you start from the head to toe, you can have intracranial hypertension, you can get stroke, you can have cardiac heart disease, you can have diabetes, hypertension, you can have sleep apnea with the lung function abnormalities, you can have a fatty liver or the cirrhosis. Before, alcohol was the biggest cause of cirrhosis. Now, obesity is the biggest cause of cirrhosis of liver. You can have a cancer, breast, uterus, colon, esophagus. There is infertility, polycystic ovary problems. You can have arthritis, backache. So any organ can be involved with obesity. So what is the impact of obesity on the survival? So currently in Europe, 8% of the population deaths are because of the obesity and overweight. And it also leads to a significant portion up to 44% of diabetics or a quarter of ischemic heart disease. And even sort of 7 to 40% of certain cancers are because of obesity. And we know for fact that smoking causes 50,000 cancers in the UK, whereas obesity is up to 20,000 cancers, the cause of cancer. So in Europe League, after Hungary, we are the leading in front of incidence of obesity. And when people try to look in what are the impact of obesity on the life expectancy, it can lose up to 8 to 10 years with a BMI more than 40, up to 3 to 5 years BMI more than 30. And as I said, the 8% deaths in the Europe are because of the obesity. And currently the obesity sort of costs around 15 billion and it's going to rise if you don't do anything. So what are the impacts of obesity? It causes other diseases we call comorbidities like diabetes, hypertension, sleep apnea. It reduces one's quality of life. There's increased chance of morbidity and mortality, and there's greater healthcare costs and a loss of economy. So obesity is also called bariatric and metabolic surgery. Baros means weight, that's what it came. But because of some stigma attached to obesity and the terminology and the benefits of metabolic benefits after surgery, now it is termed as metabolic surgery. It is not a cosmetic surgery. It doesn't involve removal of any fatty tissue at the abdomen or in the buttocks or anywhere else. What it does, it reduces the gastric reservoir and there's an element of malabsorption. And the aim is to improve the health through a durable weight loss. It improves some of the comorbidities and improves your daily living or quality of life. So why surgery? We know non-surgical treatments are not effective or effective in a small portion of patients. And various studies, one of the key studies, the Swedish obesity study or called the SOS study. We know this is running more than 20 years. And there are few randomized trials which show that you can lose significant weight by surgery, but not by medical treatment or other conventional treatment. And it can improve or cure some of the diabetes or obesity-related diseases. And we know that it has become safe and the risk of dying from surgery is very, very small, whereas the risk of dying if you're obese is high. So this is a Swedish obesity study I was talking. If you see, this is a 15 years time period. But if you see, if you got a medical treatment, there's some ups and downs. But if you have surgery, of course, we stop doing bands now. So if you do bypass, there's a significant weight loss there. And this is again bariatric surgery versus non-surgical medical treatment. Again, a systematic review and meta-analysis means a good quality study who is showing that surgery has an effective weight loss and improves quality of life and it reduces cardiovascular related deaths. So what are the current NICE guidelines or National Institute of Clinical Excellence given some guidelines? It says that if a BMI is 35 or between 35 and 40 or BMI more than 40, you are suitable for surgery. You fail to achieve or maintain weight loss for 6 months through non-surgical measures. You're receiving treatment in a specialist bariatric service or tier 3 service. There is no medical or psychological contraindication. You're fit for surgery and anesthesia. You understand and commit long-term follow-up because you know the more long-term you follow up and commit, the better the outcome. Because in Asian population, the guidelines that you can have a 2.5 less BMI point because their muscle mass is less and their higher incidence of diabetes. Currently, because of the benefit of weight loss or bariatric surgery following for especially for diabetics, the NICE has reduced the BMI to 30. So if you're 30, you're diabetic, then surgery is an option. So what is the history of bariatric surgery? So surgeons started in 1950s, sort of probably 70 years ago, when surgeons started noting that when a lot of bit of stomach is taken out for ulcers or cancers, or you have a large amount of small bowel exercise, whether for a hernia, gangrene, or a trauma, accident, then these people start losing weight. That's why surgeons started using the stomach and the small bowel to do these surgeries. So because of the benefits, now we call it metabolic surgery. So as I said, people started noting in 30s and 50s. The surgery started in sort of mid 50s. Then people did animal study and randomized trial. And currently in 16, the diabetic care in the American Association of Diabetic had said this is the standard of care from the Diabetic Surgery Summit. So you can see the new scientist commented is one of the most significant changes in treating diabetes since discovery of insulin. So what is the evidence? So all these randomized trials are what you call the level 1 evidence. It shows there's greater improvement in glycemic control or blood sugar level, reduction in medication use, reduction in cardiovascular risk, reduction in heart attack, stroke, cancer, and overall mortality, greater weight loss, and better quality of life. So if you compare those who don't have surgery or control patients than who had surgery, over a long term, there's risk in reduction in cardiovascular and mortality risk. So how does it work? There are various ways. One, there are gut hormones change, the ghrelin, the GLP-1. There is increased bile acid pool. There is alteration in the gut microbiome, gut microorganisms, and it also senses nutrient sensing. What it does, it increases the insulin secretion so that can cure your improves the production of insulin. It utilizes better utilization of the insulin in the tissues, liver, and muscle, and it increases satiety and causes weight loss. So as you can see, the mortality risk is very, very small. 0.08 means 8 out of 100,000. So what are the types of surgery? You can do a restriction, make the small stomach, or you can do a malabsorption, or you do the bypass. So this is the band. It started sort of 20 odd years ago, but now the band slips. People do lose a bit of weight, then they regain weight. So in Salford, we don't do any bands. We take the bands out, and normally we take probably 30 bands a year because of the potential risk. So it has become out of favor. So this is the sleeve. You can see this is the stomach. We've taken this bit of stomach out. I'll show a small video. I'll just run past through it. So this is the position. The patient normally stand between the legs, and the patient is anesthetized. You are fixed into this table, and everything is done keyhole surgery. So you are putting the ports, and this is the surgery. So this is the stomach. We're cutting the blood supply on the greater curvature of the stomach using this harmonic scalpel, which sort of cuts and stop the bleeding. And so this is sort of freeing the upper part of the stomach. So once we taken all the blood supply on the greater curvature of the outer aspect of the stomach, we ask the anesthetist to pass a bougie through your mouth. The key being, we don't want to make the sleeve too tight that you can't eat solids, you can enjoy your life. So once you freed everything, you see there's a tube coming down to the stomach. So then we use the staple guns to excise the excess amount of, or we say pretty much 3/4 of stomach out. So we use there are 3 rows of staples so to stop. And sometimes you can use different things to reinforce the staples and use some, because of the tissue is healthy, you may get a bit of bleeding from the staple line, but you can control with some clips and some tissue spray. So once it's done, we check with methylene blue dye through the tube to make sure there's no leak or no concern at the time. And this excess part of the stomach is the one we excise, we'll take it out. Then this is the sort of end of the surgery. So this is the bypass again, making a small pouch in the stomach. So there's a video I will run past through. So this is the video. So this is the liver which is retracted. That's why we put it on the liver dye to shrink the liver so it can move around. We make a small pouch in your stomach. So this is the stomach. We're making a small pouch. We just made an opening in the stomach pouch. Then you bring the small bowel. We need to make sure that it's not tense or tight. Then we make an opening in the small bowel and we use the staples to join them together partly. Then we like to do the suturing so can control any bleeding or any tear or anything and can close this. Once we have done what we call the pouch jejunostomy, then we bypass the small bowel so that the bile goes down, it doesn't come into the stomach in the standard what we call the 2 joining a Roux-en-Y bypass. So we open the small bowel there, bypassing sort of around a meter and a half a small bowel. Then we use another sort of white staple gun, we call it. Then again, we close those openings. And then we disconnect because this is a technical part so that there are, now we check again with the blue, make sure there's no leak from the staple line or the joining we're done. Because you swing the bowel with the two joining bypass, we have to close the, what I call the potential internal hernia spaces. So this is the small bowel mesentery. Otherwise, there is a risk of hernia. Even though if you close, there is a 1 in out of 100 risk of hernia over many years down the line. So how do we select which operation for whom? We take a good history. You can talk on sort of whether you got a sleep apnea, got a reflux, you got diabetes, or you got a or a reflux or a kidney function, how big is the liver. So we look into all these factors. So this is what, when you come to the 4-slot clinic, you listen to the talk by our dietitian and bariatric nurse, then you see our physician, then you see one of our surgeons, then we will look into all these factors, then you decide which is the best way to go. And what are the complications of surgery? So we talked about the band we don't do anymore, but the slippage or erosion. Any joining we can do, there's risk of leak or the staple and leak within a sleeve. Because you move the bowel in and out, there's a small chance of bowel obstruction. You can get a clot, DVT or PE. That's where you will have the tinge of iron at least for a week. If you have a history of DVT, PE, we give for 4 weeks. Like any surgery, even though you do surgery, there are mechanisms. Obviously, you have to comply and listen to a dietitian and the team so that you get the best outcome. Otherwise, the risk of failure, the longer you follow up, you don't do the changes you're supposed to do, then there's a risk of failure. And the risk of failure can be 5 to 10%. But if you follow 10 to 20 years, it may be 20%. So it's very important that you, once you achieve the goal, now you have to comply, get the best out of the surgery. And always a risk to life, but as you know, the risk of life of not operating is higher than risk from surgery. And you need to take the supplements like the iron, the multivitamin calcium, otherwise you can have vitamin and mineral deficiencies. So normally you stay 1 or 2 nights hospital, but we need to make sure that you're comfortable, you're not in pain, you're tolerating fluid, you're up and about, you're happy, we are happy, let it go. Then Jody will probably give you a call a week later with telephonic, then you follow them again, 3 weeks. So then you'll have 3 follow-up calls. And the follow-up is normally periodically 6 weeks, 6 months, then up to 2 years. Then you have a choice to be followed by our bariatric physicians. And of course, you're happy to support and join our bariatric support group. And this is sort of the National Bariatric Registry. Currently in UK, we've registered more than 80,000 patients. And you can see at 2 years, people have lost their diabetes near normal in 65% of patients. And people have lost up to 60 to 70% of the weight, depending what surgery you've had. And people looked at the cost, and we know when they did the economic analysis, it is the commonest thing is that you can get your money back by 3 years' time. So this is some of our patients. So Lisa had surgery in 2014. You can see the change, dramatic change she has got. This is Linda, Simon. See, they look so different. And John, I mean, he's now done the half marathon now. Christine again, Tony. So now, because of the stigma and a lot of anxiety with obesity, we created a group called the Oasis, Obesity Awareness Support Group Information Service in Great Britain. We created about 6 years ago, me being chair, but I got a lot of big team, our bariatric nurses, Jack. And now we encourage the patients who lost the weight to become a community champion and be an advocate to tackle obesity. So we gave these trophies to our champions who lost weight, and now they become part. This is Jack, my co-chair in this is Dr. Gajana, he's a plastic surgeon. And Jody is clapping, she's enjoying the fun there. And this is sort of Chris, our dietitian here, Jody there. And these are the patients you've seen. Now they are the champions. So we want you to get your health back and be a champion. As we know, obesity is preventable, but if it's there, if you don't deal with it, you will get all the problems, diabetes, cancer, heart disease. So what you need is a sort of prevention or simple ABC, which is adopt a new healthy lifestyle, balance your calorie intake, and control the weight. Thank you.
Thank you, Professor Senapati. That was really informative, absolutely brilliant. And yes, you're right, a few of you had keen eyes there. We did have some additions of some video footage. I'm sorry if anyone was squeamish, but it is interesting, and I hope the majority found that helpful as well. So we're going to go to the question and answer section of the evening. Abby has keenly been looking at the chat. So I'll hand over to Abby and you can fire away with questions.
Yeah, feel free to continue putting the questions in the chat if you have got any. But I'll get started with the ones that we've had so far. One of the questions that we've had is about, well, someone's asked about what will happen if they don't meet the minimum weight loss requirements, if there are any before surgery, due to their weight fluctuating as a result of medication. So they've lost the weight already previously, but it keeps going back up a bit.
Yeah, I think this is a really difficult. Obviously, when you're in your tier 3 weight management programs, they will have some targets. It could be 5% or 10%. It tends to be from when you're at your heaviest within that program to when you're at your lowest at the point that they're trying to refer you. And I think it's basically that by adopting some of the processes and lifestyle changes and dietary habits, it's sort of proving that you can lose weight and can stick to these things. It's not something that perhaps all of us over at the surgical side of things completely agree with, but it is a criteria that many of you have. So I think if you've got those deep concerns and you're really showing that you're doing everything you can with the program and making adjustments, you must talk to your tier 3 weight management service, because they have a team meeting about your referral, and I'm sure things will be taken into consideration.
Sometimes we do get patients who the weight fluctuates for various reasons, but if they have done the tier 3, all the requirements, we not only look into their current weight, the weight before, or any comorbidities we think it will be improved by surgery, we still consider, we still see patients with 36 BMI, borderline diabetic and doing things. So we not only just look one episode of or a one weight, we look to the whole picture, and then that's why we have a multidisciplinary team meeting with experts on different fields. So we look everything into consideration before you decide what is the right thing for you.
Great, thank you. Another question about surgery. Can you choose which type of surgery that you have, or you recommended one? And how would the type of surgery be decided as well? Yeah, normally at the initial consultation, I just said they'll see the dietitian or bariatric nurse. Now the video, they get the videos, but they will see a physician, then they see the surgeon. At the end of the clinic, once all of us seen the patient, then you will see the psychologist, the dietitian. We all have a multidisciplinary team meeting where we take into consideration what is the right choice for you. We always take a patient as a center stage. And if you say, no, I want a sleeve, not a bypass, then we will explain you what are the pros and cons, what is our clinical expertise, which is number 1, which is number 2. We don't decide per se. We discuss it together. This is a joint venture, and we want to be in the center of this decision making. Brilliant, thank you. Another question about surgery is how long are you in the hospital for, and when can you expect being able to go back to work? So normally most people stay 1 or 2 nights in hospital. Obviously, if you're using a sleep apnea, you've got a CPAP, then you got a slightly bigger, higher monitored place. But the key thing, most people stay 1 or 2 nights in hospital, but we don't see just as a 1 or 2 nights. What we want to see that you're comfortable, you're not in pain,
your observation's okay, you're tolerating fluid, you're up and about, you're seen by the team, and the dietitian, Jody, or bariatric nurse, then you are happy, we are happy, we let you go with all the advice. So some people, if there's a complication or some people aren't right, we just make sure that you're right. Normally, my advice is take it easy for a week or two. If you got more pain or concerning, we wanted to know. Otherwise, after a week or two, most people can go back to their activity. And I had patients, so after 2 days, they're back to doing their work. So we say, take it easy for a week or two before you jump in to do what you do. Obviously, it depends what sort of activity you do. If you're a physical active person, probably take it longer. But if you're office-based work, you can take maybe a week or two.
Brilliant, thank you. I saw a few people chatting about stitches and staples that are used in surgery. Are they needed to be taken out, or do they degrade over
I think
time?
the picture I showed you, the staples, but nowadays we don't put any staples. There is normally a subcuticular stitch, means a stitch under the skin, then you don't need to take it out. If you got staples, very rarely for any particular region, somebody that has a band, who had a big infection, big wound, we may put because of the risk of wound infection, then it needs to come out usually 7-8 days. They all will be planned and arranged by the district nurse.
Great, thank you. And then after surgery, is there surgery for excess fat removal or skin removal after surgery?
No, the surgery is a metabolic or diabetic or bariatric surgery. So we'll have a sleeve or a bypass. Those are the two common operations we do. And normally you have to recover from it and the weight loss has continued. And the current guidelines, NICE guidelines, is you have to wait for at least 2 years before any sort of plastic surgery. We don't do plastic surgery. And we don't, as I said in my slide very clearly, bariatric surgery or metabolic surgery, weight loss surgery is around restriction or the bypass operation. We don't take any fat, anything out. That has to be reassessed, looked in by a plastic surgeon expert in the field. And there will be a long, windy way to go to the plastic surgeon after you've lost the weight. So you have to take the challenge, I think.
Thank you. After surgery, what is the aftercare requirement? Is it a special diet for life, or is it a normal healthy diet that someone would have to follow after surgery?
I can take this one. So yeah, after surgery, we like you to have little sips, little and often. And then at the next day, we'll come and review you, making sure that you're moving around, because that's so important to get that gut motility going again. And then you can slowly increase. You've got a tiny capacity. It's a little bit swollen at first. So if you have too much too soon, it just kind of sits there like a block pipe, and you might burp it up and it'll go down, or sometimes you might even regurgitate it a little bit. So we do prefer you just to go nice and easy. You're not dehydrated because we've given you a drip in your arm. Your mouth will feel dry because of the work the anaesthetist has done. So you can hold water in your mouth and so on, but you're not actually dry. So you mustn't try and knock back fluid. Just little sips, walk around, and it all soon goes down quite easily. And then we'll let you have half cups of tea. In fact, you'll probably always have a half cup of tea, because a full one would definitely go cold before you manage to finish it. And then you'll have the first meal, which is always a beautiful clear soup, which they'll bring in a gigantic bowl, and a pre-packaged jelly, which again is usually bigger than what we'd like you to have. We want you to attempt it with a teaspoon, and if you had 6 to 8 teaspoons of each over 20 minutes for your first meal, that's great. All we want to know is that things are going down easily for you, and you're not being sick, and that you're feeling good in yourself. And then Chris and our dietitians will already have given you good information before. When you come and meet the team, we give you lots of written information. You now have lovely videos of us to watch as well, just so you feel that you really know what you need to do with that diet. And no, we don't really like to follow a diet. We want diets to be a thing of the past for you. We want you to initially wean your stomach like a newborn baby. So you'll go from fluid to puree to mash with a fork texture, and then slowly on to full solid diet around the 4-month stage. So it isn't a hurry. We want you to heal beautifully for the rest of your days, but it can be quite individual, and that's why we do our follow-up calls and the follow-up at 6 weeks and 16 weeks, just to make sure that you're progressing as you should. Everybody needs to get back to a full solid diet. It's very important. Food's incredibly social, so you mustn't miss out on that, even if you are a cheap date and always have smaller portions. Sometimes one of the wonderful things about bariatric surgery is that people don't often feel hungry, and they see the weight loss coming off them. So, but don't ever be tempted to think, well, I'm not hungry and I'm losing plenty of weight, I just won't bother with that meal, or I'll skip this one. It's actually an indicator of weight regain in the future. Your body needs protein. It needs to know it's getting nutrition, or it goes into a bit of a starvation mode, and then it can be quite an unhealthy weight loss, or even that it stops weight loss altogether. So it's really important, if you can do one thing now before surgery, get into a regular eating pattern of a breakfast, a dinner and a tea, because it's essential after surgery.
Great, thank you. Am I right thinking we got Stewart on as well that has had surgery?
I can see him. Hi, Stewart.
We've got a question here which I think Stewart might also be helpful for, which is, are you in a bit of discomfort after surgery? Is it painful?
Right, so no, I don't think you are. I think you just you are aware that you've had the surgery, and I think you just want to make sure that you don't do any damage. I didn't go through much discomfort. I think that the more discomfort I had was after surgery, you get a lot of trapped wind in your chest, which goes through to your back. And that discomfort is there. And it's only because of the gases that the surgeons have put in, that discomfort stays with you for about a week or so. But I can't explain it. It's just like a shoulder pain more than anything. But I think really for where the surgeons do the cuts, that's fine. It's just that's the discomfort more than anything.
Great, thank you, Stewart. This might be one for you, Jodie. Can you have a baby after surgery?
Oh, yes, and be careful, because as you go through rapid weight loss, you might find yourself a bit more fertile than perhaps you'd like, especially if you're 45 plus. We have had a few ladies caught out. So yeah, so a good message there. We do hope for some people that they might actually be having the surgery because they're hoping that it'll increase their fertility chances. So we do say, please wait 12, ideally 24 months before trying to conceive after bariatric surgery. And that's mainly because a baby, as lovely as they are, is a parasite while it's growing. It will take everything it needs from you, and as it should. So we want you to be in the best place you can be after your rapid weight loss, back onto good nutrition, able to take all your supplements and tablets easily before you start thinking about having a baby, and all the joy that brings. So yeah, so we'll try and wait that 12 months. And then, as I said, it's really important that you ladies think about your contraceptive methods as well.
To add into that, yeah, leave it for 12 months, use contraception or whatever you need to, then you can try after a year. But if you become pregnant, make sure that you let your obstetrician or the midwives know, because you need to double the dose of the supplements. So, and we are there across the phone. If any issues, they can always contact our team here in Salford.
Yeah, absolutely. You can breastfeed as normal. You can consider normal ways of having birth after bariatric surgery as well. But within those first 2 years after bariatric surgery, make sure your teams are aware, and that you also let us know, because you should be in our follow-up, and we can help guide you and your obstetricians, midwives, and so on.
Thank you. I've got a few questions about some certain medical conditions and surgery. So firstly, would having a hernia impact being able to have bariatric surgery?
Yeah, you can have the surgery, but we don't advise the weight loss sort of bariatric surgery and hernia same time because of the risk of infection. And the hernia general surgeons say, oh, lose weight because risk of complications and problems, wound infection are higher. So I think we may have to decide what's the best surgery. Sometimes the bypass may be tricky because the small ball may be trapped in the hernia. Then we may decide the sleeve. That's what, when we see the patient, we look the whole picture. The patient, any issues, medical conditions, surgical, then we decide what is the best option. Yes, once you lost the weight, then you can see a general surgeon with regards to hernia. So that then reduces the complications from your obesity, and also the recurrence, the wound infection, they're all less after the weight loss surgery.
Great, thank you. And can having bariatric surgery reduce the likelihood of becoming insulin dependent as a type 2 diabetic?
Yeah, the commonest, so now because of the benefits of diabetes, it's called the metabolic surgery or surgery for diabetes. And we know if you're on medical treatment and if your diabetes is less than 5 years, there is reasonable pancreatic reserve to produce. So then surgery itself can make you long-term remission of diabetes or may cure. But normally we don't say cure, you have to closely monitor. And the requirement for insulin, suppose you may be around insulin, if you're taking insulin, there is 50% chance that you may come off insulin or the dose requirement will come down. In the past, they say type 1 diabetes who are insulin all the time, they were contraindicated for surgery, but I have seen in my experience, people with sort of type 1 diabetes and insulin, their doses come down after even weight loss surgery. So it is always good news for diabetics. And of course, we need to choose which is the right operation for you, most likely a bypass. And you need to closely monitor your blood sugar after, because some of the patients who are on medication, 1 or 2 or even insulin, they immediately come off those medication insulin and you just have to monitor.
Great, thank you.
Abby, I did see a few go up about, there was a lady asking about a condition called scleroderma. There was somebody else asking about epilepsy. So when you're in your tier 3 weight management program, there will be a physician attached to that team. So you can ask those questions there as well. But when you get referred for surgery, we have a multidisciplinary team meeting, a multidisciplinary team approach. And we have some amazing endocrinologists who are diabetologists, who are our bariatric physicians, and they will look at those conditions. They'll explain if there's additional risks. It doesn't mean at all that you can't have surgery, but there may be factors that we need to consider, and maybe it would affect the type of surgery you'd have. And that would depend on the medications that you have to manage those conditions. So all of those things will be taken into consideration, but we have had patients who've had scleroderma, epilepsy and so on, and they've had bariatric surgery successfully, but it's just things that you need to keep that extra eye on. And again, you must be really good with your follow-up, because we are always, and especially the medics who do the yearly follow-up for the rest of your life, they're an excellent source of information for anyone who comes across new health conditions as you go through your life as well. So absolutely take the benefit that Salford has that yearly follow-up to offer.
And thinking back to improvement of certain conditions after surgery, would there be any improvement in sleep apnea?
Yeah, there is sort of 60 to 70% chance of not using the CPAP, and it could be even higher. So sleep apnea is an indication, like the diabetes, sleep apnea is an indication for surgery. Of course, there is a small chance of failure, but most of the times your quality of life better, you're not snoring, so your partner is happy now.
Great, thank you. We've got a few questions about what happens once a referral is sent from a tier 3 program.
Okay, so the referral has to go through the correct funded pathway. So sometimes it's actually your GP that does the referral, so that you come through to the service, and then once that's happened, you go on the waiting list for meeting the team, which is usually you'll get a letter saying you're having a phone call on the first week. That's actually an education session with myself and Chris, and we tend to contact you to join that via Teams. And then the following week, you come to meet the team, have your bloods taken, weight done, meet the medic, meet your surgeon. And the time it can take from referral to that appointment can be 5 months at the moment because of the delays and backlogs, and the fact that not only did coronavirus impact our hospital capacity, it also meant we had to close down our outpatients, and then every time we sort of got going again, we were shut down again. So we have had delays through those clinics as well.
And is the waiting list on a first come, first served basis, or do you look at age or medical conditions, BMI?
So normally the standard waiting list, but if the patient were referred for some serious comorbidities like cancer, or they've got other problems, then we expedite them. Or they're waiting for further surgery for infertility or other hernia repairs. So that's what this multidisciplinary team meeting is, to see who can serve the best, and that's what is, all the factors are considered.
Great, thank you. Another question about after surgery. Are there any foods that aren't well tolerated?
Not
yeah,
well,
absolutely. So Chris, our dietitian, if he was here, he would say, yeah, there's some things that are really quite stubborn. So you tend to find certain meats, red meat, so you wouldn't be reaching for the steak straight away, that's for sure. But then things that might surprise you, like bread or rice or pasta. Sometimes early on, stringy vegetables, salad, they don't go down so very easily, and it could take 4 months until perhaps you're enjoying a salad easily. It is quite individual. It does also, if you imagine now your stomach's so small, you could swallow something quite quickly and it could just be in there for hours, churning around and reducing down to go into your small bowel. Now things are going through so very quickly, you need to use your mouth as that tool before things go down. So you really got to learn to chew your food really, really well before you swallow. So some people just don't so much have an intolerance. It's just that maybe they've just been gone that bit too quick, not chew quite enough. But very quickly you learn your restriction, you learn how to adapt to that. And it is easier to do once you've had the surgery, but something again to be mindful about beforehand.
Okay, great, thank you. Just sifting through to see what we haven't answered. If someone has been referred and their health deteriorates or changes, do they need to update the team at Salford Royal?
yes, please. We need to know if there's any alteration, so we can see whether they need to be expedited or they're delayed, because somebody having treatments for something else which is sort of life-threatening, then they take the priority. So we would like to know, so then you can see where it sits in.
And the majority of your tier 3 weight management services on referral, knowing how long delays are actually keeping you on their books and offering some maybe as like a support service or so on. So, you know, again, if you're not sure how to get hold of Salford Royal or how to update anyone, because obviously you've not met us yet and you haven't got a surgeon, then let your tier 3 service know. They'll be able to make us aware of that as well.
Great, thank you. Can you please explain the liver reduction diet? And it might also be helpful, Stuart, if you give us what your experience was of it as well.
So the liver diet basically means you're taking 800 to 900 calories a day. And there are various types of diets. You can Google it, or you can have a 3 slim fast, or our dietitian can give an advice. Basically, the concept being, one, it takes some of the fat from the liver out. So that is easy, because you need to retract the liver to do the laparoscopic operation or the keyhole operation. We pretty much do 100% laparoscopic. We don't do open surgery, unlike in the past. It also gets your head around that, okay, I've decided for a new life, new change, and I have to start it now. And then you start sort of thinking, okay, I can deal with it and I need to move on. Of course, some people it is easier, some people it's difficult, because a lot of the people have done yo-yo diet in the past and they have some experience. I'm sure Steward will tell us more.
Yeah, well, the liver shrinking diet, basically, I stuck to the team give you a pamphlet and it tells you exactly what you should eat. It does allow you to have quite a bit of vegetables and salad as well, so that you don't have to be at a point where you feel that you're starving. It's imperative that you've got to do this, because otherwise, if you don't shrink your liver enough, the doctor won't do the operation. I mean, I lost within it should have been 2 weeks, but I ended up with 3 weeks because my surgery got put back a bit, and I lost 11 kilos alone just on that liver shrinking diet. It allows the doctor then to be able to lift your liver out of the way so that he can do his operation. If you don't lose that, then obviously you're going to struggle. But I didn't find it that hard. The liver shrinking diet was quite good. I actually felt a little bit better after that, to be fair, but it wasn't as hard as you probably think it would be.
Thanks, Stewart.
Thank you. We've got another question for you, Stewart, as well.
Yeah.
Has the surgery and the new relationship with food impacted your social life at all?
Yes, it does. It's a bit difficult to say at the moment because we haven't been allowed out. We've been locked in. But going out for meals, if you get a decent enough restaurant, they will understand when you go out that your dietary needs, and a lot of restaurants will actually help in that respect, and try not to cook with certain oils and certain fats. I mean, that's what you got to stay away from, the fats and the oils. Otherwise, you're going to be ill. You are ill from that, because I mean, I've had the gastric bypass, and that just doesn't allow or tolerate certain foods, as in fats and sugars. It sort of trains you to stay away from them because you don't want to be ill. I don't want to be ill, and the last thing I want to be doing is literally having the dumping syndrome. I've been very lucky in the fact that the way I've kept and stuck to the diets that the team give us, that Geordie and everybody tells you what to eat, and you stick to them diets, and you will be okay. I've not very often been sick. I've had the other way, and I'm not going too deep into what that's about, but you can probably make that up in your own mind. And then that probably more than any. But generally, being sick, I've sort of stayed away from that. I'm now at a point where I can eat most foods, but you just generally stick to staying away from anything that's fatty or full of sugar. And you can replace that with sweeteners and spray oils, and there's a lot of spray oils out there that you can adjust to. But generally, life's good now.
Brilliant, thank you. And you mentioned dumping syndrome.
Yeah.
Would someone mind just explaining what that is?
Yeah, I'm happy to tell you that one. So dumping syndrome, basically, as I was describing before, you haven't got that stomach to churn everything round, and things go very quickly into your bowel. So if you have anything too sweet, too starchy, or too greasy, your body's not used to that. It comes into the small bowel, it doesn't like it, and it wants to flush it through and get rid of that offending item. So to do that, it's going to draw fluid from your circulation, which means your blood pressure will suddenly drop and you'll be like, oh, I don't really feel too well. And then so sit down, elevate your legs and think to yourself, what have I had to eat or drink in the last half hour or so that could be causing this problem? And your body's quite smart. Maybe you'll have diarrhea, maybe you'll be sick, maybe you'll just feel a bit rough for a while. And sometimes you can even get late dumping, which can be some 3 hours after normally something very sugary. And that's where your blood sugars are messing around a little bit now, and you might get palpitations, you might get a headache, you might feel a bit sweaty and clammy. But your body will soon sort it all out and you'll be absolutely fine. But you'll say to yourself, I am never going near that petit falou or whatever it was that you tried where you got caught out. Because very rarely do people get dumping because they're trying things they shouldn't. It's usually because the sugar content or whatever was on the label was a bit misleading.
Brilliant, thank you. Going back to the surgery criteria, is there an age limit for surgery?
No, normally we don't look into age limit. What do you look into? Physiological age. Somebody we think they're safe to operate. If we have any concern, we will ask our anesthetist to assess the patient as well. So if you're physiologically good enough, and we'll probably plan the surgery. So like anything else, we look into the risk benefit ratio. And if you think somebody is 65, 66, but they're fit reasonably well, their heart is strong enough to go ahead. So that's what, like anything else, patient selection and the real indication and the safety is our drive.
Great, thank you. And another question just taken into consideration is, taking age into consideration, is a client that's asked if they'd have to wait 2 years after having surgery for IVF. So they are being referred because of infertility. How would the surgery impact IVF, or how could needing fertility treatment also impact a referral as well?
So that's what I'm saying. Sometimes if the delicate situation, so somebody in 40s or late 30s and considering IVF is all recommended, the weight is a problem, that's what we need to know. So if you let the tier 4 service know from the tier 3, so these are the criteria, these are the reason, then if we think they're relevant and it is going to impact the patient's sort of quality of life or the pregnancy, we will try to expedite them.
Thank you. Are there any restrictions or problems with those with IBD disorders such as ulcerative colitis?
So colitis is not a contraindication, but obviously if it's only colon, probably doesn't make a difference. It's only the Crohn's disease where you don't know, because Crohn's disease can affect anywhere from your mouth to the back passage. So that's what we need to look in. So if your disease is controlled, or if you got a stoma, then that's okay. You may get a frequency diarrhea. So then we have to plan. If you had surgery before, your bowel may be stuck, then instead of doing a bypass, we may do sleeve. So all those things need to looked into in detail. Then that's what when we in the consultation, we look into the pros and cons, the impact it is. That's what we look into all those things into consideration. Then decide, but it's not a contraindication.
Great, thank you. The question maybe for you, Jodie. If a referral is sent over to Salford, is there anything that could impact it being accepted at Salford Royal?
No, so essentially the only way we can accept a referral is from your tier 3 weight management program. So essentially when your referral comes to us, as long as those criteria that Professor Senapati explained in the presentation have been met, then your referral go forward. And we work quite closely with all the tier 3 weight management teams, so it's very rare that someone would be referred to us that wasn't ready. And that's something else I really want to touch on. I know a few of you have said, oh well, I might have infertility issues, or I might have this condition, and yes, in theory, absolutely bariatric surgery would help. But if you're not ready for bariatric surgery could potentially be very dangerous. So it's not a finite, oh, you have this condition, so therefore you must be referred at 6 months. It might be that you have other issues that need addressing as well. So that is why you go through the service that you're in right now, and it's with that team, and they're very aware of the criteria and for referring and so on. So of course do address those with you so you can feel reassured and comfortable with the team that you're with. But it's not a definite you have to be referred to because you have this condition, because frankly surgery wouldn't work if people don't understand it and know how to live properly after with it.
Thank you, Jodie. Would bariatric surgery help lower someone's blood pressure?
Sorry, can't hear.
Would bariatric surgery help lower a client's blood pressure?
Well, normally the bypass, there's a 50% chance, but the sleeve bypass, 50% chance of blood pressure down, according to the evidence. More likely bypass than the sleeve, but it is very dependent. And what is the cause of your diabetes? Is it hormonal or what hormones? So various factors to look in. But the evidence suggests that your BP medication probably come to 50% reduction.
Thank you. Just scrolling through to see what we might have missed.
Don't worry, you're doing a great job, Abby.
Someone's asked again who decides which surgery you have, but I think you mentioned earlier, Siba, that it's a joint
as I said
decision.
before, this is we all decide together. The patient is at the center of who can tell you what is the right for you, and sometimes, but we take the decision is made with you, not separate from you.
Great, thank you. And someone asked earlier, is there any difference in risk between the different surgeries?
Yes, because in a bypass, you had a small bowel to use. So there's a risk of leak or obstruction or internal hernia, all those things. Whereas in a sleeve, because you take part of the stomach out on the staple line, so that may be different. Yes.
Thank you. And will having several DVTs in the past stop me from having surgery?
No. If somebody had DVT in the past, we will look into that, and they need to be on the sort of tinzapirin or deltapyrin perioperatively, and they will have take longer. And if they are already in apixaban or warfarin, they continue. So we'll minimize. So it is a balance. It's a fine balance with the bleeding and problem and getting a DVT or PE. So that's the balance act we need to do.
Thank you. And we did discuss earlier about recovery time and going back to work after surgery, but what about doing things like going back to the gym or swimming after surgery? How long might that take? Yeah,
well, I'd say once the scars have healed well, sort of first week or two sort of thing, keep walking and up and down, just sort of simple stretching things. But once the scars have healed, which is very likely, so normally I say by sort of 3 to 4 weeks, you can start doing the swimming, but anything more than that, by sort of 4 or 5 weeks, you can simply slowly but surely start training whichever way you can do.
Thank you. And quite a specific one. How long after surgery do you have to wait before getting back on a roller coaster?
Well, depending how good your heart is.
Yeah, good answer.
Oh, we've got a good question. After surgery, is there any chance of you regaining the weight?
I just said surgery is part of the process. The sleeve gastrectomy, where it's driven by the ghrelin hormone, the restricted stomach, the bowel, sort of the food going to a small bowel faster. So that's one way of working. The bypass, again, small portions, then the hormones, all those things. But we also know that at the scars and the joinings of the heel, they get a little bigger. Unless you change the lifestyle with you, and the longer you follow up, the evidence across the globe, well, across the globe, we do 500,000 bariatric surgeries. And the longer you follow them up, if you follow them 10 years, 15 years down the line, then up to quarter may need something doing that. Are they all revisional surgery? We don't know. That's what we say. You made the decision. You have to work it. You had the benefit first 2 years. Now you have to work with it. Otherwise, you may land up in a bigger problem. Then revisional surgery has its own complication, then further failure. So it's very important. What you're doing is for your health and your longevity and quality of life. That's the drive.
Yeah, thank you. And what has your experience been with that, Stewart, of managing your weight after surgery?
It's fine. I started off at 28.5 stone. I'm now 12.3. 12 stone 3, 12 stone 4 I think I am. So I still lose a little bit. I think since I'm now 2 years in, or I am 2 years in at the 15th of May. Since Christmas to now, I've lost probably roughly about half a stone. So I'm now maintaining my weight, but you've got to stick. I could probably actually go and get a bar of chocolate if I wanted to now and eat it. That's at the point I'm at now, but you've got to stick to that diet. That diet's there, not just while you're losing that weight and while you're trying to lose to get to where I am now. You've got to carry that on. That diet's, it's a lifetime. So the doctors have helped us for the first 2 years. Like the doctor just said, then you just got to carry it on. I'm carrying it on. I'm still eating my salads. I'm still eating my baked potatoes. I'm enjoying that food now. There's other ways to eat and enjoy food without putting that fatty stuff and that sugary stuff in. But yeah, I'm quite happy as I am now. I'm quite happy to keep still sticking to that diet and following what the team have told me to do. They give you a tool. You've now got to use that tool. It's not for them to help you once they've operated, they've done their bit. It's now for you to do what you need to do. If you want to stay slim and you want to stay that weight off, you've got to do it.
Thank you. And a question that ties in nicely with that, is it okay to drink after surgery? I'm not sure if this means alcohol or soft drinks, but what's the sort of guidance with that?
So normally you avoid the fizzy drinks. The alcohol will hit you fast, so it will be a cheap date. And because they are full of calories, you need to be careful how much you want to drink. So that's the key. But the common advice to avoid it at least for 3 to 6 months. Then I'm a bit easygoing. I say, yes, once in a while, you can have a glass of wine or something. So, but be sensible. You can't just go on, okay, I will have this weekend, I'm making 2 bottles of wine. Then that's not good.
Thank you. I've got a few questions asking about what if they can't achieve the suggested weight loss before referral. Jodie, is there anything else that you think indicates someone would be a good candidate for surgery?
It's difficult. I'd almost throw that one back to you, Abby, because obviously you guys in the Tier 3 weight management service are absolutely doing your best to work with people to become really, really self-aware. I think obviously obesity is the pandemic that society has forgotten, and society is built on convenience foods and doesn't really support that long-term weight loss after surgery, and certainly hasn't supported healthy weight for you throughout your lifetime. We all know that this is a real issue for everybody. So yeah, it is difficult. Essentially, if there are medications that you take that people describe as weight gaining, it may sound cruel and flippant, but actually it's an appetite stimulant and it's making you feel hungry. So you tend to eat more without realizing. So I think really it's that journey of self-awareness that can really help when you're looking at how you can control your weight by what's passing your lips. And that's really difficult sort of mindset. I think from patients that have had surgery, when they reflect back, they think, I always thought my portion size was normal, but actually it really wasn't. And it was just the way you were brought up, or it could just be what goes on in your family unit. And we just presume it's the same for everybody. And it isn't, it really isn't. So yeah, I do think that just that self-awareness, to be honest, is something that I've noticed those people that kind of go through that after surgery, not being too precise, you know, obviously it's good to know what you're eating and being aware of that, but body and mind as well. So it's a huge process psychologically. So knowing where you are, knowing where you were, where you've come from, where you are now and where you want to be is a really, really important part of it all for long-term success with weight loss.
Thank you, Jodie.
Maybe you must have covered most of the questions now.
I think so, yeah, just
Excellent.
about. Yeah, just got one more. Can gallstones be removed at the same time as surgery?
Yes, technically can be removed. If the patients are having symptoms at the time, it can be removed. But again, that sort of increases the length of surgery. They complicate it may be a little challenging at the time, but if you're having symptoms, we can take it out at the same time. And we also know that patients who will lose the weight rapidly, which will happen after weight surgery, who do not have gallstones, or, well, in fact, if you walk in the street and do a scan, 20% people will have gallstones, but only 10% of them come with the problems. So you might have the gallstones, now they may flare up. So then that needs to be dealt with. But if you're having a lot of pain and problem, we can take at the same time. Or when you lost the weight, it is technically easier and your local surgeon can do it.
Thank you. If someone manages to lose a large amount of weight in the next 12 months before surgery, would they still be able to have weight loss surgery?
Well, I just said, when they refer to the service, what are the BMI, what are the weight loss there? Obviously, if you lost the weight and you probably, if you think you're a borderline, you're not need to, probably you don't need surgery. But that's not our criteria. If you have the weight loss, if you have the weight before, when you attended the tier 3 service, if you still fits into the nice criteria, and if you understand, you still can go to have the surgery.
Great, thank you. Just having a scroll through, see what else we've got. Jodie, just for anyone that might have joined on a little bit later, would you mind just explaining the how it is at Salford-Royal at the moment in terms of surgery and the waiting list?
Yeah, so at the moment at Salford-Royal, we have 6 surgeons who perform the bariatric surgery, and they are unable to do any elective surgery. So there is no elective cases of bariatric surgery happening at Salford. Obviously, each surgeon has their own waiting list. And for me to work out waiting times, or rather for the service managers and the secretaries that keep their surgeons' lists, they need to know when and how many theatre slots their surgeons are going to have on a regular basis. So there are definitely, I'm trying to tell up from the last time I was told, it's over 120 people waiting for surgery. And because we see people every week, that list is increasing. And without knowing exactly what capacity we're going to be allowed. It's difficult to know. But yeah, if you think of 6 surgeons with well over 100 people on those waiting lists, and we have got people going back to 2019 that haven't had surgery yet. So though it is lengthy, it's a really sad and tough time for the bariatric service at Salford. There's no two ways about it, and I'm desperate to be able to give you some good news to say, right, we've got a regular list, and we still haven't. So that's something that the team are really quite saddened by, and frustrated for you all. So I am sorry that those delays are still there, and I haven't got anything to update you with that, but I'll always tell you what I know, and that's the best I can do, I'm afraid.
Having said that, out of the waiting list of the patients, if they have problems or there's a high risk, we are, because of the COVID risk has come down, there is some things happening. We've done few small lists or high risk or other patients waiting with symptoms, this and that. And hopefully with the COVID situation coming down, unless there is a sort of third wave, we should be progressing because we got now 6 surgeons.
Yeah, you're right there. So Professor Senapati has hit on a point there. We get referrals that are urgent all the time, and sometimes there might be a space at the end of that list, and your surgeon will go to the elective list of the long waiters, people that have got other conditions that have been accounted for as being a higher priority, and put those people on the list. It's just that that's a trickle of activity, so it's difficult to be able to equate that to be able to say, oh, we're doing surgery again. And so where we can, we do, but at the moment we don't have those regular lists.
Great, thank you for that.
All right then, everyone. Okay,
So
once again, thank you everyone for coming along.
Yeah, I've put the we've got a feedback survey. I've just put it into the chat. I'll put it back in again. It just gives you an opportunity to let us know what sort of information you'd like to get in future sessions as well. Just a reminder, they're on the first Wednesday of every month, so you can get in touch with your coach, whichever program you want, to get the new link for that session. But thank you very much, Professor Senapati and Jodie. There's really good comments about how informative it was tonight.
Brilliant, you're welcome.
Thank you. Good evening. Bye-bye.
Bye-bye now. Bye.